All right, welcome. I don't think I've ever spoken holding a handheld microphone before. It was a little odd. All right, so I'm a pediatric epileptologist working at Children's Hospital in Los Angeles. I'm fairly new to California. I'm from the East Coast and I talk fast. I don't know if that's because I'm from the East Coast. I actually grew up in Ohio. But nonetheless, I talk fast, so everyone try to keep up the room nice and cold so we'll all stay awake. So we're going to talk a little bit about how we treat children with epilepsy, and we're going to go over kind of our sequence of events and how we manage kids with epilepsy. I'm a pediatric doctor, so I generally take care of young children, although we see kids up into their 20s, so they're not really kids anymore. But everything I say applies to adults as well, so if any of you have older kids or adult patients, this applies to them as well. And then we'll cover the basics, and then we'll take time for questions, so if anyone has questions, we'll answer those as well. So typically we're dealing with patients who have failed medication. So we know in epilepsy about 70% of patients respond to the first medication or the second medication and can live their lives pretty normally with epilepsy, doing quite well with the first or second medication. And then we have 30% of patients who actually fail medications. These are our drug resistance or medically intractable patients with epilepsy. And the interesting thing about this 30 or 35% of intractable patients is that number hasn't changed over the last 30 years. Which is interesting because we've added about 15 new drugs to the market in that time. So you'd think we have all these new drugs that are, we think, better drugs, but actually we're not any better at treating intractable epilepsy. So even with all these new drugs on the market, we still have 30 to 35% of patients who fail drugs. So the new drugs are better tolerated, we have fewer side effects, but they're not any better at treating epilepsy. Patients who failed drugs in the 70s still failed drugs in 2015 despite having all these new drugs on the market. So when do we know if you're medically intractable? We actually know after the second drug. So statistically, if you fail 2 drugs, the likelihood a third drug will work is under 10%. It's actually closer to 5%. So you don't have to try 10 or 15 drugs to know that drugs aren't going to work for you. You actually only have to try 2 drugs. Because the likelihood a third drug will work is only 5%. So once you've failed those 2 drugs, you really should be asking your doctor if you can see a specialist in epilepsy. And those are doctors who have had extra training and treat patients with this intractable or drug-resistant epilepsy. And the first thing we do when we see those patients is we take a step back and we say, what am I treating? Am I treating epilepsy? So sometimes I get patients referred who are having a funny spell that looks like a seizure, and someone's been treating them as if they're epilepsy, and we do EEG monitoring and we find out that's not even epilepsy. That's maybe a tic, or that may be some behavioral problem, and they've actually been treating the wrong disease for the last 2 years. And it's not even seizures, and that's why the medicine doesn't work. So you always want to make sure you have the right diagnosis first before you go on with further treatments. So I don't see that too often, but we do sometimes come across that. So after you've failed 2 medications, the first thing you want to do is confirm your diagnosis. And that's done with video EEG monitoring. So it's interesting, there's some places in this country where it's actually very difficult to get video EEG monitoring. Where I work at Children's, we have specially wired beds in our hospital where we admit patients, we have EEG in them all, and we have video cameras mounted in the ceiling, and we can do video EEG monitoring, we can capture your patient's, your child's events, and we can tell you exactly what it is. We can tell you if it's a seizure, if it's not a seizure, and if it's a seizure, we can tell you exactly what type of seizure it is. Is it a focal seizure starting in one spot in the brain? And if it is, what spot in the brain is it starting? Is it a generalized seizure where the whole brain fires at once? And we can tell you exactly how long the seizure is lasting and how it's affecting your child. But there's some places in this country where that's not readily available. I recently went to Hawaii and gave a talk, and there's only one monitoring unit in Hawaii, and it's only on one of the islands. So patients have to fly to that island if they want to get monitoring. There's some states where you may have to travel to another city to get monitoring like that. So it's important that if you have seizures and they're not controlled with the first or second medication, that you find a place where you can get video EEG monitoring. And it's important that you don't just get EEG monitoring just at a random time. It's important that you actually record the events. Because you can have a completely normal EEG just when you're awake and minding your own business and doing your daily activities and still have epilepsy. And seeing an EEG when your child's not having a seizure is not going to tell me what's going on during the seizure. I have to actually see the seizure. I have to see the event you're worried about, and that's the only way I can tell you exactly what type of seizure it is. And it's the only way I can tell you what the best treatment's going to be and how we can fix those seizures. So it's really important that we record the seizures on the video EEG monitoring. And once we record the seizures, then we can tell you if you have focal seizures or generalized seizures. That's really important. So why is it important to know if you have focal seizures or generalized seizures? Because they're treated differently. Different medications work for different seizure types, and different treatment options are available for different seizure types. So if you have focal seizures, There's some medications that work better, and there's some medications that don't work as well. And it's even worse for generalized seizures. If you have generalized seizures, there's some medications that may actually make you worse and may actually cause you to have a very long, dangerous seizure. So it's really important that we know what type of seizures you have so we can use the right medications. So video EEG monitoring to record your seizures so we can tell you exactly what type of epilepsy you have. We can give you the name of the seizure type, and we can go even into more detail, and we can tell you exactly where in the brain your seizures are coming from. And once we can figure out all that information, then we can tell you what the best treatment option is. Now, often with that test, we also take a picture of the brain called an MRI. An MRI gives us a very detailed picture of the brain, and it helps us know if there's something in the brain that may be causing your seizures. So if we find an area of abnormality in the MRI that's causing the seizures, that's something we may be able to surgically remove, and that may offer a chance to get rid of your seizures forever. So an MRI scan can be very useful in figuring out what the cause of the seizures are. So most patients, when we do our evaluation after medications have failed, the minimum we're going to do is a video EEG monitoring study to capture seizures. One seizure may be enough. Sometimes we like to see 2 or 3 seizures, depends on what we're looking for, and an MRI or a picture of the brain. So once we have all that information, then we're going to sit down with our patients and families, and we're going to discuss what options we have. So right now, in 2015, for children, we have 4 ways we can treat seizures. It's better than what we used to have. When I started doing this training, we only had a couple of ways, and now we have 4. For adults, we have 5. So adults are a little luckier, but for kids right now, we only have 4. So we have medications. That's what we try first. So if you're coming to see me, you probably have already failed medications. So medications may not be your best option, right? The likelihood the third medication is going to work after 2, we already said, is only 5%. So if you're in this drug-resistant category, medication is not going to be your best option. So what else can we do? We have 3 other options. So we have diet therapy. So this morning, Dr. Partikin gave a lecture on ketogenic diet and talked about diet therapy. So we actually have a couple of diet options. We don't just have ketogenic diet. So ketogenic diet is a high-fat, low-carbohydrate diet. So there's some folks out there with Boost that have information on the diet if you want more detailed information. But basically what you do with the diet, normally our brain uses sugar for energy. That's how our brain supplies itself with energy. If you switch your brain from using sugar for energy to using fat breakdown, which is ketones, seizures can get better. So as soon as your brain switches from sugar to ketones, seizures get better. The problem with the diet is if you give your body any source of sugar, it switches right back to sugar, and then the seizures can come back. So this is a high-fat, low-carbohydrate diet. Similar to Atkins, right? So everybody's heard about Atkins. Some people may have even tried Atkins to help them lose weight, right? So it's a low carbohydrate. So no cereal, no sugar, no rice, no cookies, no cupcakes, nothing sweet. So it can be done. Patients can be very successful. There's lots of good recipes you can find online. And if you're successful in the diet, your seizures can improve. About 2/3 of patients have success with the diet. And many patients can be seizure-free. So this can be a very good option for patients who have failed medication. So we have lots of patients that try the diet and do quite well. For some patients, we can use the Atkins diet, just like you do if you want to lose weight on your own. You don't have to go to the full ketogenic diet. You can use just an Atkins diet. We call it modified Atkins diet. And we give you a total number of carbohydrates to take during the day, normally around 15 or 16. Anybody have any idea how few carbohydrates 15 and 16 is? Yeah, someone have tried it. So a bowl of cereal, how many carbohydrates do you think are in a bowl of cereal?
45.
Right, so people know this. So about 45 in a bowl of cereal. That's like
without the milk.
Yeah, without the milk, right. Milk has a lot of carbohydrates. So that's more than your entire carbohydrate amount for the entire day. So even the modified Atkins is pretty strict. But if you're motivated, especially a motivated teenager, you can be successful. And if your whole family wants to do it with you, it's even better. Everybody can lose a little weight and be healthy. So you can do the modified Atkins diet or the ketogenic diet. We follow these kids closely. You're going to be vitamin deficient because you're not eating a well-balanced diet, so you have to take vitamin supplements. And we make sure they're growing, they're gaining weight. We have special dietitians who work with us. But the diet is a good option. It's a good option for children. It's a very good option for kids with special needs who have feeding tubes because we have carbohydrate-free formulas we can use. So for that patient population, this can be a really good option. So diet is a good option for patients who have failed medications. It works for all seizure types. Doesn't matter if your seizures are focal or generalized or where they come from in the brain, the diet can be a good option. So that's something to keep in mind if you have patients who have failed medications. So what else can we do? We can do what we call neuromodulation. So this is changing the brain from outside the brain, using some type of external stimulation to change the brain. The option we have right now is called the vagus nerve stimulator. So has everybody heard of the vagus nerve stimulator? Does anybody have the vagus nerve stimulator? We have a couple patients with the vagus nerve stimulator.
Well, next week.
And so I'm getting the vagus nerve stimulator. So the vagus nerve stimulator is an implantable device. It's implanted like a pacemaker in the chest wall. The wires wrap around the vagus nerve, which is a nerve in the side of the neck. That nerve goes up to the brain. And basically the way it works is it turns itself on and off all day long. Typically it turns on for 30 seconds, off for 5 minutes. Does that all day long. 30 seconds on, 5 minutes off. 30 seconds on, 5 minutes off. It stimulates this nerve in the neck, sends information up to the brain, changes the way the brain works, and seizures get better. We really don't have any idea exactly how it works. So we've been using it since the late 90s, and we still don't know exactly how it works. But it can work for any seizure type. Nothing works for everybody, but it can work for anybody. Anybody with epilepsy who fails medications can respond to the VNS. Now the VNS also comes with a little magnet, and when the patient's having a seizure, if they feel their seizures coming on, or if a caregiver, a parent, or guardian sees a patient having a seizure, they can run the magnet over the generator, turn it on, and in many patients that will stop a seizure. So that was kind of the old traditional VNS. The company came out recently at the end of June with a new VNS, taking advantage of the fact that most patients when they have seizures have an increase in their heart rate. So most patients, even patients who just have focal seizures, where they just maybe stare and are unresponsive, still have an increase in their heart rate during their seizures. So since this device sits next to the heart, they took advantage of this fact, and this device has a little EKG machine in it, and it senses your heart rate all day long. So all day long it's sitting there looking at your heart rate, and as soon as it sees an increase in the heart rate, it turns itself on and aborts the seizure. So it not only turns on all day long to prevent seizures, but if you were to have a breakthrough seizure, it sees that increase in heart rate, turns itself on, and stops the seizure. So you don't have to use the magnet anymore. You don't have to feel the seizure coming on and swipe the magnet, or have a parent or caregiver swipe the magnet. And the nice thing about using the heart rate to abort a seizure is it does it before you even see the patient have a seizure, because the heart rate is the first thing that changes. So it can stop the seizure often before the patient even knows they're having a seizure. So this is something new that just came out. This is not available on the old VNSs. This is only available on the new one. So this is a new feature, and we like this feature because we think it's going to be helpful for patients that have nighttime seizures, right? When no one's around to swipe the magnet. So for patients that have seizures where they don't get a warning, where they don't have someone with them to turn it on, and for patients who have seizures at night. So we've had a lot of success with this in our first 12 to 15 patients that we've implanted, and it seems to do a good job of picking up these seizures and turning itself on. So this is something new that's just come out and is an option now for patients who have failed medications. For VNS, like the diet, it doesn't matter if you have focal seizures or generalized seizures, and it doesn't matter where they come from in the brain. These options work for everybody. Not everybody responds to each option, but it can work for anybody. So those are the two options. Medication was the third option. So the fourth option is brain surgery. So the surgery is the best option if you're a candidate, because it's the option to cure your epilepsy. Right, so these other options are just treatments. They help prevent seizures and decrease seizures. Surgery, if you're a candidate, is the potential to cure your epilepsy. The downside is not everybody's a candidate, right? So in order to have epilepsy surgery, your seizures have to be focal. They have to come from one spot in the brain, and it has to be a spot a surgeon can go in and take out. So we can't take out every spot. We can't take out the spot that controls your arm or your hand movement, because then you won't be able to move your arm or your hand. We can't take out the spot that controls your vision, because you won't be able to see. Right? We can't take out your language spot. You won't be able to talk. So we have to find a spot that's safe to take out, and a surgeon has to be able to get in and take it out safely. So the way we work someone up for surgery is we do our video EEG monitoring like we talked about earlier. We find where your seizures are coming from. If they're all coming from one spot, then you may be a candidate for surgery. And we have a couple of ways we can do surgery. If the spot your seizures are coming from is easy to get to, and we have an abnormality on the MRI, a surgeon can just go in and take it out. If you have something funny on your MRI, say you have a tumor that's not a bad tumor, a little small tumor, or a funny spot of brain development, sometimes the brain gets confused when it's developing and you have a little spot of abnormal brain cells that a surgeon can see, they can just go in and take it out. We do EEG recordings in the operating room to make sure they get all the bad brain out to help guide them, but they can just go in and take it out. You go home a few days later, hopefully seizures are gone, we're done with epilepsy. Sometimes it's not that easy. Sometimes the brain's normal, or the area on the MRI is big and it's abnormal. We can't tell the exact spot where the seizures are coming from. And sometimes we have to do a bigger procedure, what we call brain mapping. And the way we do this is we do the regular video EEG first. We put those stickers on the outside of your head, we record your seizures, and we find the area where the seizures are coming from. So let's say your seizures are coming from the front of the left side of your brain, up here in the front. That's a pretty big area. Let's say we don't know exactly where they're coming from. We just know they're coming from the front left side. We put that sticker on their forehead, and that's where they're coming from, under that sticker. So we have a region, but we don't know exactly where. There's an important brain that lives in the front of your left side, and the back of the frontal lobe is where your motor strip lives. That controls your right arm and your right leg. So we don't want to leave anybody weak, so we have to do a little more precise planning. We just can't go in and start cutting out your frontal lobe because we don't want to leave you with any weakness afterwards. So what we can do is we can do a two-stage procedure. We can have the surgeon take off the bone and the protective covering of the brain in the operating room, and we can actually implant EEG electrodes directly on the surface of the brain. And then we put everything back together, and the patient goes back to the monitoring unit, the same place where we recorded seizures before, but now we record seizures from these electrodes that are sitting right on the surface of the brain. And the nice thing about doing this type of surgery is the brain actually doesn't have any pain fibers, so the brain doesn't actually feel pain. So this is not a very painful procedure. There's some pain from the skin being cut and the bone being cut, but usually patients after the first 24 hours actually feel pretty good. And our kids actually tolerate this procedure pretty well. They need very little pain medication for this type of procedure. So we record seizures from these electrodes sitting on the brain, and we can tell within millimeters exactly where the seizures are coming from. We can tell the exact spot on the brain where those seizures are coming from. Then after we're done recording seizures, we use those same electrodes, and we do a procedure we call brain mapping, where we give a little electrical stimulation to the brain, and we map out the entire normal function of the brain. So we can find your motor strip, we can find your language area, we can find your sensory area, we can find any normal function we need to find by stimulating the brain with a little electrical stimulation. And that way we can give the surgeon a detailed map of your specific brain, unique to you, and tell them where the seizures are coming from, where the bad brain is, and we can tell them where all the normal brain is, where your motor strip is, where your language area is, whatever we're looking for. If it's the frontal lobe, we'd be looking for your motor strip. That way when we go back to surgery, the surgeon can take out just the bad brain and leave all the normal brain in place. So we can give you a very good chance of being 100% seizure-free and leave all your normal function intact for our patients with intractable epilepsy. Surgery, if you're a candidate, probably best chance. Neuromodulation, VNS, what we have right now in the 60s. Diet therapy, also in the 60s. And then more medications, which are already decided is not a good option, because that's where we started all this, that you failed medications, probably in the 5th percentile. There's some other options available for adults. The option that's available for adults is another type of neuromodulation called responsive neurostimulation, where they actually implant electrodes on the brain in the area where the seizures are coming from, and it records EEG, and when it senses a seizure, it actually stimulates the brain right there where the seizures are coming from. That device is not approved yet for children, so it's not something we have available for kids, but it is available for adults. So those are the options we have right now for kids. It's better than what we used to have. It's not the best because we still can't fix everybody. We still have patients, even with all these options, who are still having seizures. I know all of us who take care of kids with epilepsy would like to fix everybody, and we're not quite there yet. But we're better than we were, and I'm sure in 10 years we'll be better than we are now. But at least we have options, and that's always good to have options. So that's what we kind of think about, and that's how we kind of take a patient through the workup procedure and what we think about when we see new patients in clinic. And those are the options that we have currently available to us right now. There's some other surgical options that we have for other cases, which are kind of specific to each patient, so we won't go into all the details. But if there's specific questions, I'd be happy to answer any. Yeah.
What would you consider a medication failure? Let's say I have typically like maybe 2 or 3 breakthrough seizures a year. Now, while some would probably consider that controlled in some way, they're still like devastating when they happen. You know, like they're full grand mal seizures. You know, so would you consider that a failure of a medication?
Yeah, I mean, I like everybody to be seizure-free, right? And 1 seizure a year still means in many states you can't drive, right? And it's still hard to be alone because you don't know when that 1 seizure is going to happen. So I think any seizure is a medication failure. The question is, how aggressive are you with trying to get that last seizure under control? So, I mean, I think we need to still keep trying if you're having any seizures, right? More questions? No questions from nobody? Wow.
Once an ECG is done and it's discovered that, well, in our particular case, that it's coming primarily from the left-hand side, which is affecting our memory, how can we go about, how big a range of a variation of degree can we see that is varying? Would genetic testing be something to consider at that point, or?
Yeah, so it's difficult to say with little information, but genetic testing is usually done if we don't find an underlying cause. So if the MRI is normal and there's not an underlying cause for the seizure, then genetic testing is usually recommended. So there's a lot, and we didn't even talk about genetic causes of epilepsy. There's a lot of genetic causes of epilepsy right now which can be tested. Depends on what state you live in. You live in California?
Yeah.
So it's very difficult to get genetic testing in California, I found when I moved here. I've only lived here 2 years. The rest of the world, the rest of the country kind of figured out that genetic testing is important. California is a little slow to come to the table. They still consider it experimental in most cases. So I've really struggled to get genetic testing for my patients. But I think it's important if there's not another cause. So usually we look at the MRI first. If there's an answer on the MRI, then you don't often need genetic testing. But if there's not another cause, then genetic testing is important because it may give you an answer. And the reason genetic testing is important is there's some genetic diseases that certain drugs make worse and some genetic diseases where certain drugs work better. So it's nice to know that beforehand, right? Otherwise you may pick the wrong one and cause bad things to happen.
Exactly.
So, I mean, in my perfect world, everybody when they're diagnosed with epilepsy would have the genetic testing done. And we would just know from day one what to do and what not to do. But California doesn't get that yet.
Do you have anybody to recommend in California?
Well, it's just hard. The insurance companies don't pay for it. And it's not a matter of the doctor ordering it. It's a matter of the insurance company saying it's experimental. So I have a patient right now, I'm on my 3rd appeal.
Oh.
And they still keep telling me it's experimental.
Oh.
I don't know. I keep telling them it's not, and they keep telling me it is. So, it's this uphill battle. Where in the rest of the country, they kind of got it a little earlier.
Off the top of your head, do you know what states do?
Right. So I've worked in 4 other states, and they all do it. So it's just, it seems to be, California seems to be the last one that still seems to be a problem.
Interesting.
Yeah.
Okay, well, thank you.
Yeah.
Or did you have they do epilepsy genetic testing. If you can get the doctor to write the prescription and your insurance denies it, they have a grant plan.
Yeah, so some of the genetic labs will do it.
And that one's just a saliva test, so it's not an invasive one.
So some of the big labs will do it for a discounted price.
Okay.
Yeah, it's Cornigen with the C.
Yeah.
Okay, thank you.
Yeah.
So our daughter has myoclonic epilepsy.
Mm-hmm.
She goes into myoclonic status when she is on the heat.
Mm-hmm.
She has an
Very
SC1A mutation of unknown significance. Ooh, VNS.
Sounds like it's not really unknown.
Well,
It
yeah,
seems
exactly,
sensitive,
exactly.
right?
Yeah.
What they haven't figured out is relevant.
Exactly. So VNS, would that still help even though she's with the heat triggering?
Yeah, so VNS actually works well for generalized seizures. It's only officially approved for focal because that's what they did the study on, but we've actually found it works better for generalized, which myoclonic is a generalized seizure type. So we've had good success with VNS and myoclonic seizures in our patients. The automatic swiping may not activate because the seizures are so short, but once they start coming back to back, it probably will.
Right.
And you can still use the magnet.
And the medication has worked great for her myoclonic, short myoclonic, when she has status on the
Right.
heat.
Yeah, so the magnet may help, and that autostim feature, if she has enough myoclonus and the heart rate goes up, it'll trigger it.
Yeah.
So yeah, we've had good success with the VNS and the myoclonic. Yeah, heat's a problem, especially here. Do you live out here?
No, we live in Kansas, but she's on Topamax, so it makes it even more of a problem.
Yeah, that's a problem.
Yeah.
You kind of a double whammy there, huh?
Totamax, you can't go outside.
Yeah.
You're just
Yeah.
That's
Bad
a
combination.
complicated procedure.
Yeah.
These guys are going to talk about it right now.
Can I just ask a question? You know, there are many different, several different dietary therapies, the low glycemic,
Right,
all
yeah,
the
we
way
can
to
talk about autoglycemic.
So, why is it with people that one will work for? Why can't people go into ketosis? Certain people, like you were talking about the cereals, 45. Some kids have 10. Some people have to be on the ratio. Why is that?
We don't know why some people go into ketosis easier than other people.
Okay, but
Yeah.
it's the ketosis being in there.
It's the ketosis that seems to have the seizure control. And actually, we don't even know really why ketosis controls seizures. Right? I mean, we've noted since there's reports in the Bible of people going out and fasting in the desert and their seizures getting better, but we don't even know why ketosis actually improves seizure control. They're still trying to figure that out, and we don't know why some patients get into ketosis very easily and some don't. So it's still a bit of a mystery to us, but it is that getting into ketosis that seems to produce the seizure control. So if you can't get into ketosis, then the ketogenic diet may not be the best option for you, which then that's the downside, right?
Right.
Take maybe one more.
Yep.
And,
Yeah, sorry.
I've heard that essential oils is supposed to supposedly be helping in certain things, and a couple of people have told me to try it with my daughter with having essential oils as like the main thing? Have you ever heard of
Like on oils for the diet or just in general?
just in general?
There's no scientific evidence.
Okay.
So,
What about the cannibal?
yeah, so there's also no scientific evidence, right, on the CBD oil. We could talk a whole hour about CBD oil. So right now, there's no scientific evidence on whether CBD oil treats seizures, right? So, you know, there's some news stories and there's people reporting that their children have responded. We have a lot of patients who have tried it. I've yet to see anyone become seizure-free. We are currently doing a number of drug studies at our institution. We're using a company that got it, that has it grown in a lab and then purifies it. So we actually know what we're giving. The problem is you buy it on the internet, you have no idea what's in the vial, you have no idea where it was grown, you have no idea what you're giving your child. The other problem is it interacts with the seizure medication, so you have no idea what you're doing to the regular medications. So you definitely want to let your doctor know if you're going to use it so we can monitor medication levels. And the other big concern is we have no idea what CBD does to a developing brain. So you're risking your child's potential development because we have no idea what it does. So there are a lot of drug studies going on right now in the country. We're participating in a couple of them, and I think within the next year or two we'll actually have some scientific evidence. And it's usually better to wait till there's scientific evidence before you give something to a child.
That's interesting because they geared it towards your cognitive development, and it's not even approved.
Well, it's never been studied, so there's no scientific evidence. There's never been a drug study on it, ever. So we're doing studies right now, and we're doing the good studies where you compare it to a sugar pill. Right, so you get medication in a sugar pill, and the doctors and the patients don't know what they're getting, and you actually study it. That's how drugs get approved. And so we're studying it the same way a drug would be studied. It's very difficult to study an illegal substance, so it's really difficult, right? So you have to get approval from the DEA, get special safes in your hospital so no one goes and steals it. So it took a while to get it done, but there are a number of hospitals in the country. Children's LA, where I work, is one of the hospitals participating. So there are a lot of hospitals in the country who are now actually doing formal studies. It'll take about a year to a year and a half to actually get the data. And we're looking at it for a number of different seizure types. I have a number of patients who have tried it on their own, and I can tell you in my experience, none of them are seizure-free. So it is not the miracle drug people make it out to be. The original patient who was in the CNN story still sees it every day. So, you know, it's not that miracle drug people made it out to be. And I think it's very worrisome to give your child something that we don't even know what it does, right? So you just have to keep that in mind.
Thank you.
Thank you.